and I'd like to thank Armstrong Medical for the kind invitation to talk to you today, particularly Nigel and Carrie for organising and getting me up here. So I'm going to talk to you today about a kind of a general overview of high-flow nasal oxygen. There's a lot of fantastic speakers that are going to follow me with sort of more specifics, and there'll be a bit of overlap, but I think that's important to actually see that we're all on the same page and we're all trying to use this newer technology more efficiently and for the betterment of our patients. I work in a university hospital. We're the second largest head and neck cancer centre in Ireland. We do over 300 major cancer cases of head and neck a year. We also do an awful lot of diagnostics, obviously, and surveillance, panendoscopy. So we have a lot of use for this particular type of technology as it comes in. I do have some disclaimers. I obviously was paid to come up here in terms of my accommodation and travel, and I previously got a travel burst to present some of the research I'm going to show you at the ASA last year in Boston. I have no financial other links otherwise to the company. So the overview of my talk is that I'll talk about the physics of high flow, some of the literature that's out there in our evidence base, such as there is. Just a brief bit about the setup, some brief examples because other speakers will talk in more detail, and then a little bit of data I've garnered from my own patients that we've looked at for some specific areas of high flow nasal oxygen. So the first thing is, how does it work? Well, that's a really good question because we're not really sure, all right? This great kind of phrase from Patel maybe encapsulates everything we know about high-flow nasal oxygen. The idea that it's flow-dependent, non-rhythmic ventilatory exchange. So you can impress your juniors with that phrase, or you then have to delve deep into the physiology high-frequency nasal oxygen. So I have for this talk, and it's very, very interesting. So this was actually first looked at back in the early 1900s by a number of German physicians, and described in 1988 by Vollard. And what his proposal was that inflating oxygen into the airways resulted in a gradient between oxygen and carbon dioxide. Obviously, we use up oxygen and we produce carbon dioxide. And he was able to demonstrate some evidence in dogs' experiments of up to a 20 centimeters of water negative pressure gradient with this absorption of oxygen and then production of carbon dioxide. So there may be this idea of a ventilatory mass flow, so the air is just moving in and out of the airway purely on the basis that we are taking in oxygen, using carbon dioxide, and that causes a movement of air. About a year later, there was some, again, experiments in dogs, a tracheal intubation with high flows by Metzler and Ivers, and they showed that giving high flows of nasal oxygen into the trachea directly resulted in prolongation of apneic periods with continuing oxygenation. And I suppose more recent science has shown us that with higher flows of nasal oxygen, certainly more than 60 litres per minute, that's quite important, the lower flows don't seem to give it. When you actually check the oropharynx and you look at the oxygen with an oxygen sensor, you find that you get an oxygen level, an FiO2 of 0.89, which is extremely high. There's very few things that will actually do that outside of complete bag mass ventilation. So this is one of the highest levels of oxygen you get in your oropharynx. There is definitely some gaseous mixing when it comes to using these higher flows. You can actually feel it when the patient opens their mouth. And there's definitely gaseous mixing that occurs in some of the modelling that's been done in terms of the pharynx in particular, and then down towards the trachea. There is a positive pressure, so PEEP as such, that's produced by high-flow nasal oxygen. And obviously we know that PEEP improves oxygenation. We use it all the time in intensive care. And the PEEP varies depending whether the mouth is closed or open. If it's open, about 2.7 centimeters of water, and if it's closed, up to 7. Okay. Other studies have shown around 3.8, 3.9. So somewhere between around the 4 to 7 potentially PEEP, which is generally kind of acceptable to improve lung expansion, improve your functional residual capacity, and reduce atelectasis and improve oxygenation. So again, another reason why it might work. And then obviously if you have high flows, like a river of flow, a river of oxygen in this case going down, you get a flushing of the dead space. And as you know, dead space, particularly for spontaneous breathing patients, so this is more in the ICU setting, you get a reduction in the need for minute ventilation. So you reduce the work of breathing and patients are more comfortable. And certainly there's, I suppose, a lot of information now, and increasingly quite a number of studies, in fact, now in intensive care literature, showing that high-flow nasal oxygen is very useful in patients with ventilatory distress or impending ventilatory failure, and probably comes in roughly equal to non-invasive pressure ventilation, but probably tolerated a bit better. Now, again, there's a little bit of mix, and my talk is not intensive care, but certainly there's data that's very supportive of high-flow nasal oxygen in our more critically ill patients before they try and prevent them getting to intubation. And we know that it probably increases functional residual capacity. Obviously, trying to experiment and test this out is very, very difficult in humans. There are a number of key requirements, though, if you're going to use high-flow nasal oxygen. There are 3 main ones, in fact. The first is you need to be able to blend oxygen. Okay, you can give 100%, But as you see later, some people say in terms of laser surgery, we need to be able to drop that down. And some patients may not tolerate due to various effects of oxygen toxicity. It's always nice to be able to reduce your oxygen levels to make sure you're giving the safest and most appropriate amount of oxygen to patients. You're going to need some form of a delivery system. Okay, that's self-explanatory. It has to get from the blender to the patient. Okay, and then vitally important, you cannot give someone 70 litres or 80 litres or 60 litres of a gas dry and cold. All right, it will lead to massive problems. We know that it will lead to tracheal drying, tracheal irritation, tracheal inflammation, and ciliary function will deteriorate. Whereas if we humidify it and warm it, we will actually improve the expectoration of secretions. We'll improve ciliary function. All right, so they're the three main requirements that we have. Now to the science bit. Can't flick my hair like L'Oreal, but this is the science and nuts behind it. All right, so this is, I suppose, our first foray into actually seeing, can we use high-flow nasal oxygen in anesthesia? So this paper is 2015 in anesthesia. It generated actually a lot of literature and correspondence back and forth about it, okay? There was talk about the ethics of it, etc. But it was very, very interesting because they looked at 25 patients, Patel did in London Hospital, and they looked at them having ENT surgery. And they looked at what they call the transnasal humidified rapid insufflation ventral exchange. So everyone has to come up with a cool name, right? So we'll thrive to do better, we'll thrive to improve our oxygenation. What was very interesting about the study is that in these 25 patients, they found that they could prolong the time of apneic oxygenation, the holy grail of anesthesia. This ability to not have to ventilate the patient and the patient to be oxygenated. That's all. We'd all love that. We'd all love that. Once we give our induction agents, that actually we don't need to give oxygen for ideally as long as possible. That would be fantastic. So what they're able to show is they had a large number of patients in the 15 to 20 minutes of apneic oxygenation. All right, in a number of cases, 4 cases, they could completely do the surgery with it. In one patient, a gentleman, they had up to 65 minutes of apneic oxygenation. Right, so these are quite impressive figures. I mean, we worry about 2 minutes. We're delighted if we get 5. And someone's saying, here, we're getting 15 to 20, and we're getting maybe up to 65. It's all very tantalizing, very teasing. But of course, there's always the naysayers, and the naysayers were always saying the problem with apneic oxygenation, we all knew that we could hold open the face mask, do pre-oxygenation with the face mask, give 15 litres of flow, and we could get 10 to 15 minutes of apneic oxygenation. Big deal. There was a big deal. It's the CO2 levels. The CO2 levels would rise, and it was always a limiting factor in how long you get apneic oxygenation. You were getting acidotic, and you had high CO2 levels to get rid of afterwards once you started ventilating or when you tried to wake up. But what was very interesting about the high-flow nasal oxygen, at over 60 litres per minute, is that the rise in carbon dioxide levels was actually very, very small, 0.15 kilopascals per minute. Okay? And I think most of us would accept over 10 as a really problematic CO2. And as you see here, only 3 of the 25 patients reached that during their periods of prolonged apneic oxygenation. So that was sort of, I suppose the word game changer is always tricky, but that allowed us to start thinking about the fact that let's start pushing out the boat here, because one of the kind of adverse effects that we have isn't happening. So that was sort of the first bit of it. Now, to be fair, they went on and did further studies because people would naturally say, look, we've been pre-oxygenating for years, I have the face mask, we're used to it, let's just do it properly. So they did a randomized controlled trial, 20 patients each group, and you're randomized to either getting proper pre-oxygenation with a face mask, so proper length of time, proper breaths, proper seal, etc. And then they compared it to the high-flow nasal oxygen. And then they looked at arterial gases. All right, so they looked at PO2s, PCO2s, pH, and the duration of apnea. And I suppose what was very interesting about it is that while the oxygenation, 41 kilopascals, 43 for high-flow nasal oxygen, they're quite impressive figures. There was no difference between the two groups. There was no difference in CO2 level, again, very important for both, and no difference in pH. But where the differences were is there was double the period of apnea. Now remember, they weren't going to say how long can we go on for the apnea. They were saying, let's look at a reasonable length of apnea as we intubate the patient. All right, so normal sort of practice. You don't kind of say, yay, we've got 20 minutes, let's just wait until the 19 minutes and start intubating. You start intubating, what they found is the period of apnea was double that. All right, 4 minutes as opposed to 2. And those 2 minutes are vital. They're the difference between the Elaine Bromley case and not. Okay, so those small amounts of time make the critical difference in our lives and our patients in terms of their outcomes. So look, I suppose that's the background where they are. I don't want to go over the literature. There's a little bit more that's out there, but it's all since 2015, so only 2018. But there is definitely literature supporting its use in anesthesia and significant literature supporting its use in intensive care. So what are its indications in anesthesia? As other speakers will talk about their more detailed practice and go through it in more finite. I'm going to talk, just mention that the indications include prolonged apneic oxygenation, as I mentioned. This would be very helpful if someone has a difficult airway that you predict, or you want to do an awake fibre optic and you can continue to give large amounts of oxygen while you do the nasal fibre optic. The little ports are very amenable to the fibroscope going past. Airway surgery, as I said, that's where Patel's group were looking at it. And then select patients with significant respiratory conditions where you want to avoid positive pressure ventilation. I have 2 cases actually only last week, which I just want to present to you at the end. Now, does it work? We were just amazed. This is one case we had. This is a lady actually with breast cancer, or melanoma, sorry, and she had a pleural effusion, and they were doing a debulking of the melanoma in her axillary area, and she went on her side. She was 40 years of age, otherwise healthy lady. And we kind of decided we're going to look at this. And we're going to see, do we really want to be ventilating someone on their side, basically one lung down, the whole issues of the physiological. Let's see whether we can allow this woman to be safely anesthetized with TIVA, safely oxygenated, and watch how she goes, all right? So what we did is we put her off sleep, having pre-oxygenated her with the high-flow nasal oxygen, and we waited a number of minutes, about 10 minutes, to see how would she be steady and safe, and she was. And we intubated her, and then we just left her on 1 litre per minute of oxygen through the nasal tube, or to the endotracheal tube. No more high flow at this point. And we watched, and we watched, and we watched, and we watched, and the surgery finished, and then we ventilated her to wake her up at the end, and her end tidal CO2 was 12.9. Okay, so it is possible, okay? It's not going to work for every patient, but human beings have the physiology that allows us, with the type of delivery of high flow nasal oxygen, to have prolonged, so 40 minutes of oxygenation without ventilation. Like that is an amazing thing to have, all right? So that's where we were up to. We published that in an abstract in the ASA in Boston last year, as I said. In terms of airway surgery, I won't go into too much detail on it outside of the setup. It can provide a tube-free surgical field. And I work with ENT surgeons, and one of them is just retired, very experienced, and the tube is sometimes in the way, but he works around it. And another ENT surgeon that initially were like, oh, if only you could get the tube out of the way. And it's very difficult. You intubate someone with difficult airway, you do not want to take the tube out, no matter who's going. Let him work around it. I'll give you the tiniest tube. We'll move it over. We'll swing it around. Okay. But there's sometimes when you actually you can see yourself, because you can always use a lot of laryngoscopy as well. We can see the actual lesion, and we know our tube is in the way, and it is delaying and it is compromising the surgery. So there certainly would be an advantage if we didn't have a tube there, or bronchoscopy, for instance. So microlaryngoscopies, biopsies, or laser surgery with the vocal cords would all be very nice if we could include this in it. And I said people will speak in detail on those later. The setup, so the nuts and the bolts, how do you go about it? You're going to have to become proficient at TIVA. I think, to be honest, any anesthesiologist should be proficient at TIVA. It's a fantastic way of giving anesthesia, and there are plenty of indications for it, but you want to be good at it. You can't be giving volatile when you don't have a tube down, it'll be just blowing everywhere, okay? You continue with normal monitoring, obviously. You do need a fast surgeon. I'll show you one case where we didn't have a fast surgeon, okay? So the surgeon has to get on with it, and you have to be prepared. You need a well-organized team, all right? You need to be slightly head up, and you have to be at 70 litres per minute. I'll show you some data that suggests that you really have to be at 70 litres per minute from the start. And you do need a jaw thrust or some way of preventing the airway obstructing, because otherwise it just pools in the pharynx. It doesn't get down into the trachea. In terms of the setup, what we have here is you've got this, you open the bag, it's like a lucky bag at Christmas, and out comes these very shiny Armstrong with Fabulous purple things. They do always stand out, and they're easy to find. So you'll have your nasal prongs, which I'll show you later on the patient. You have your heated plate for humidification and warming, and you have the delivery circuit, which has a number of transistors that are plugged in to monitor the temperature of the airflow. And then you have your oxygen blender. There's a more modern one we haven't got yet, which allows you down to 21%, and you have this on a stand, and you just put this to the side. Now, you do need a splitter. We unfortunately, bizarrely, have only one oxygen point in our theatres, so occasionally you're going to need a splitter to split your oxygen for your anaesthesia machine on standby and for your point setup in this case. So this is kind of the setup of one of our patients recently. We have a nice actual ward. It's a nice sunny day surgical ward, so it's large and plenty of space. Great equipment, but our TIVA is going for point connected, and we have our nasal cannulas, and the patient is anesthetized. And this is sort of the setup when it comes to surgery. So you have a non-intubated patient, you have the patient set up, and you have the surgeon operating away. And you'll see here that we have 97% saturation, 99 systolic blood pressure, 93 heart rate, all very steady, and we have no ventilation whatsoever, all right? And this is the surgery proceeding. Or so I would have hoped, but this was just one of those days where you're just not having a great day, because it was the SHO who was doing the list, because it's a registrar list in the sense that the patients were public, and the registrars are given a chance to practice and learn. It's a teaching hospital. And the nurse was over from India, and it's her first month in Ireland, and then they opened the kit and the guide and realised the microscope. So on and on and on and on this went. So we had 60 minutes of apneic oxygenation. I'm like, come on, come on, come on. And eventually the saturations start dropping, and I have to intubate the patient. No big deal. I intubate the patient. 7.1 is the end-tidal CO2, and 4 minutes later the surgeon finishes the surgery. So I was a bit upset that, you know, so that's what I'm saying about being organised, you know what I mean? So we could have done this well, and I was where an actual competent surgeon is able to do the full surgery on the patient with no delays, and the surgery was completed without intubation, using point only. Now to move on to the kind of second thing, these are two very interesting cases that came on the same list, and we have a preoperative assessment clinic, and both my colleagues who were on the previous week had gone, yeah, there'll be no bother with these patients, and I'm not doing the list basically. So the first lady, you know, you start off and she's 88, she's grossly overweight, she's ASA 3 with significant COPD, she has hoarseness and she smokes, so of course she needs to have a microlaryngoscopy, and she's had a recent cough. And I hear this and I go, okay, another heart sink patient, and she comes in and she lies down and literally, you know, brings up half her lung, and I'm like going, I'm not intubating her. So we started to use the high flow nasal oxygen, all right? We ran it for 8 minutes of oxygenation time, and then we were able to do her biopsy with, you know, you can see her saturations improved from 94 up to 99%. She had stable cardiovascular monitoring. She had no ventilation, and at the end, the only blip there at the CO2 is as we put the face mask on, take off the nasal prongs, and she wakes up. All right, so that was very, very successful. She had no kind of positive pressure ventilation, didn't have to worry about a lot of secretions in the tube, etc. The second case then that came up that morning was even worse. So this was a kind of a 65-year-old man who'd been diagnosed with lung carcinoma back in May. This was now, or May, kind of June. He'd had a PET scan that showed there was something in his piriform fossa as well, and that it needed something done. But being the jigs and the reels, what happened is he ended up with his lung cancer done first as opposed to his ENT potential cancer looked at, and he 3 weeks ago had his left lobectomy done. I really wasn't keen to take this man who was still coughing post-surgery, with the wound still open and fairly looking fresh, to actually put down a tube, my tiny little MLT tube with my high airway pressures, and blow off whatever lines and staple lines that he had. So again, what we did is I put him on the high flow nasal oxygen. We had a consultant surgeon operating. He needed to have a surgery done. And again, you'll see that a very steady state of oxygenation, very stable cardiovascular system on his TIVA, and again, only at the very end, we put on the face mask and he wakes up. All right, so again, worked very, very well. And finally, just a little bit of data, because there's a lot of advice that says, you know, high flow nasal oxygen isn't tolerated well by patients. So let's start at the 40 litres per minute initially. Well, the problem with that is it takes up time of pre-oxygenation. So you start off and you go, how are you getting on? And they're like, grand doctor, and you know, you're waiting and you're looking at the clock, and then everyone's standing around you and they're looking at the clock and nothing's really happening. And you start to use up your pre-oxygenation, saying, well, I've done 3 minutes now with 40 litres, and then you put on just around the 2 minutes or so, you get your 5 minutes kind of pre-oxygenation time, which is 70 litres. But what we noticed is that, and I'm going to go to the worst one first, the few patients we started off with by giving them 40 litres first to get used to the mask, and who had less than 2 litres at 2 minutes at 70 litres per minute, we found that their apneic times and their hypoxic times were actually very, very short. They weren't really great at all, and we had to intervene on a number of occasions. So after that, I decided I'm going to just start with the 70 litres, explain to the patient that they were going to feel this high flow of oxygen flowing them, that they would have to close their mouth and it would feel that the pressure was building up. If it was too bad, just release it. And once that explanation came in and it's warm and it's humidified, patients tolerated it incredibly well. So the difference now of going then for more than 2 minutes at 70 litres per minute is quite stark. You see out of 14 patients there, only 4 are under the 5 minutes hypoxic time, and the rest are at significant times, 10, 15, 20, 25, 40 minutes of apneic oxygenation. So we have to be very cautious with newer technology and a lack of understanding and difficulty in actually experimenting with it as to what exactly we do. So from our own data, I now start with the high flows immediately and give the time, because that's necessary to wash out, to do the gauge mixing, to get rid of the dead space, all these physiological things that I mentioned. So in summary, high flow nasal oxygen ventilation improves oxygenation, and it improves it for a long period of time. There are a number of mechanisms, and I suppose with the number of mechanisms, it means that we still have to tease out exactly how it works. There is a slow carbon dioxide rise. We know that from good data. It's very useful in anesthesia, particularly in the areas of airway surgery. I will say it can be unpredictable, and that's where we're going to hear a lot more from our other speakers about how to reduce that unpredictability, okay, and learn, because it's still new. And there's still unknown patient factors because, again, the number of patients that are being studied are quite small. But hopefully you'll see a use for it in your practice. Thank you very much.
So, thank you, Steve. I think we have a microphone.
I think we do, yeah.
If there are any questions from the audience, my colleague Kieran will get a microphone to you so that we can have those also broadcast.
Just speak into the microphone, please, as well.
Hello, hi. I'm Ramesh, one of the anesthetic consultant from North Manchester. I'm just wondering, you start at 70 liters per minute. How do the patients feel? What are they able to tolerate?
Yeah, they are, and I suppose that's one of the things that certainly, you know, if you look at Patel's studies, you look at whether it's Armstrong talking about their system, people say you've got to start small, and the problem is start low. And the problem is that my data was showing me that this was not the way to go. And to be honest about it, once patients then went on to the 70 litres, or even 80 sometimes, I didn't notice any difference. So I said, you know what, let's just go to it, explain to them what's happening. And to be honest, all they feel is this warm flow going down. You actually, if you get them to open their mouth and put your hand over their mouth, you'll feel it. And it actually feels quite pleasant, like a warm summer day with a little bit of humidity. Sounds like the perfect kind of West Cork, you know, weather conditions, you know. But you do have to explain to them that they're going to feel this almost like a rush. And that if the pressure builds up too much for them, they can open their mouth and let out. But ideally, you want them closing their mouth and saying, this will improve your oxygenation. And they seem to tolerate it very well.
Sorry, one more question.
Yeah.
Do you intubate them if they become the saturation goes down? Do you intubate them, or do you use the jet ventilation?
We don't have jet ventilation in hospital.
Okay.
We've tried over the years to get different. I mean, look, there's various debates about jet ventilation in terms of barotrauma, etc. What initially, maybe the other speakers will give you a bit more detail, but often you find an initial dip,
Okay.
and then you open the airway, and it comes up for 10, 15, 20 minutes afterwards.
Okay.
So that's important. But obviously, if the patient is going to start desaturating, you make a judgment call, and you're set up for intubation.
Okay.
You know, all right.
Thank you.
Hi, thanks for your talk. I just wanted to know, do you reduce the FiO2 when you do laser work, or do you reduce the flow too?
Yeah, so look, I suppose originally the machine was a non-blended oxygen, 100%, and I suppose that was a concern that came up with some of our surgeons. Now, the physics of it are that you can have a spark in 100% oxygen with no fire as long as there's no combustible material. So technically, if there's nothing that's combustible, you can actually light a match in 100% oxygen, nothing would happen, okay? But obviously there can be lint and dust. So we hadn't seen it, but it was a concern. I know colleagues of mine in Galway were doing somewhat more of it, and they were able to manage it, but it constantly came up as a concern. So things like oxygen was turned off at that time, so the flows were turned off. The laser would be done, and then you'd restart it. But now there's a blended system, which we haven't yet got, that people might talk about, that reduces it 21%. So that might allay people's fears. But again, it's the physics of it suggests that, let's be honest about it, a lot of the times airway fires will not happen in isolation with 100% oxygen. It's not possible.
Hi, I'm Esteban Salas from Alicante General Hospital. So I don't know if you said, but which is the lowest saturation value that your safety saturation value you allowed till you start ventilating?
Yeah, look,
when apnea.
Yeah,
induction.
I mean, I think that's the data that was initially published by Patel was 95, right? And I start off at 95, and then I start going, hold on a second. A lot of these patients are coming in at 92, 93 saturation in room air. And I'm going, do I really want to rush in at 95 when the surgeon's saying I'm 5 minutes from the end? So I've certainly, in the last number of patients, I'm now looking at 92, 93, you know what I mean? So again, I think that's a judgment call. Some studies would say 90 is unsafe, you know what I mean? So what's an unsafe saturation? I mean, we do know that children who have cyanotic heart disease, it takes them many months or years to develop problems from their low oxygen levels. I do sometimes think we over-rush in to treat oxygen levels, you know what I mean? Let's be honest, we're knowing, and it's going to come more and more, that oxygen causes harm we're probably giving most of our patients way too much oxygen in the first place in terms of tracheal problems and, of course, the whole thing of superoxidase radicals. So I think you're going to have to make that judgment on it, judging by the patient, you know. So
Depends on the patient.
Exactly. and the surgeon.
Individualized
Yeah.
patients.
Look, I knew in my case when it hit 92, this surgeon was a junior surgeon. It wasn't going to work out. I'm going to say, you know, steady the system and go back to what they know, you know what I mean? And actually, on that point, I will say that some of the junior surgeons find it a bit weird because they'd follow our tubes down to the larynx. They're not very good because they're quite junior. So when they're looking to get down to the larynx with their own laryngoscope, they use our tubes. So I found a few of the junior surgeons are like, I don't know where to go. Where's your tube? So just be aware of that fact when you're training.
Thank you.
Thank you.
Hi, I'm Linda, one of the anaesthetists in Newcastle. So can I just get a bit more detail on your recipe, really, and in practical terms what you do? So do you, when you use Tiva to get them off to sleep, do you use muscle relaxant as well or not?
I suppose it depends. You know, I mix it up really, to be honest. It depends on the patients, their underlying condition. The Tiva is very good. I mean, you know, look, I enjoy using Tiva. I've been using it for many, many years, even as a trainee. You don't need muscle relaxation. You can increase your Tiva if you want to. We also have Sugammadex, so I would you know, caveat anything I say about the use of muscle relaxants in that, you know, despite our pharmacy and our hospital saying you got to, well, we're spending $250,000 a year on Sugammadex, so it's a lot of money, euros, but we can reverse it very, very quickly, and we can reverse it very, very definitely. So, you know, I don't mind using muscle relaxation.
But you don't think that makes a difference to this at all?
I judge it each time. So if the surgeon says the conditions are not correct, I'll add in a muscle relaxant,
Yeah.
which I can then reverse.
And do you then, when you've established your point for pre-oxygenation and you get them set up on the table, do you then check that you can ventilate them so that when you, if and when you needed to rescue them, you know that you can, or do you not do that?
You see, I've always hated this idea of trying to bag the patient when you put them to sleep, because I think it kind of is.
But I mean after that. So when you've got your, you know, optimal, when you've got the conditions that you would be in if you were to rescue them. So, you know, I know that
no,
bit.
I don't.
Yeah,
I
okay.
don't, because I believe our job as anesthesiologists is to be able to manage the patient who you cannot ventilate proficiently, because you've already put them to sleep.
Yeah.
So whether you can ventilate them or not is a moot point. Do you know what I mean? You know,
It is, except you might, I don't know, my worry, having not used this much, is that you only know when it's not working anymore, when the patient starts to desaturate, and at that point you're slightly on the back foot at then trying to rescue
It's true,
them.
but I mean, there's a lot of our colleagues put patients to sleep without pre-oxygenation, and they're immediately on the back foot for every single patient they anesthetize, you know. I mean, you can certainly do that. There's nothing stopping you doing that. But as I said, my processing of airway management might be very different for a lot of other people. You know, I use a lot of video laryngoscopy. We have a technique where I described before, where I use the fibroscope and video laryngoscope. I have a different processing of how we look at airways than the kind of, you know, I don't agree with the different airway guidance that you 3 times try to intubate. You try once. The data shows you've only 20% success rate after that. So I think our whole mental processing of the airway needs to change. We've got to stop being afraid of the difficult can't ventilate, can't intubate patient. We have to embrace it so that we're ready for the challenge. So it's easy to do. You just put on the bag and you bag, and if that makes you more comfortable about how you look after the patient, go ahead. But I would prefer we have a greater discussion about airway management anesthesia and stop trying to hide from the fact that, you know, very rarely one or our patients may actually be very difficult to ventilate. What are the skills of getting us out of that? That's what I would like to teach you to base on. So I do have a slightly different view on it than a lot of people would have. You know, I get to experience different airways every day. Do you know what I mean? So I'm very lucky to have that chance to process it differently. So, but I mean, it's a valid point. But again, I think it happens for every single patient you anaesthetised. Yeah. Not just one's a point. So you have to work out how do you manage the difficult airway yourself in any patient you anaesthetise. You know.
Thank you.
Was there another?
Hi. Thank you for a very good talk, by the way. But I just wanted you to run me through the preparation at the beginning. So do you sit the patients up a little bit?
Yeah. So
do you give them nasal decongestants beforehand?
No, it's very simple. I like sitting patients up. I mean, I don't know where we got this idea of everyone has to lie flat under anaesthesia. I'm not sure where that makes sense. We all know physiology is a bad idea. But patient comes into theatre, the first thing nurse does, lies them down flat, you know what I mean? I'm like, sit them up. It's a horrible position as your patient trying to look up people. Sit people up and improve their functional residual capacity and their lung mechanics, right? So sitting them up with 30 degrees, and that's how most of my patients will go to sleep. And I just simply put the nasal prongs on, and I turn on the 70 litres. Believe me, you don't need any nasal decongestion at 70 litres of flow. You'll feel it clear them out, you know. It decongests people, do you know what I mean? So I probably do the odd polypectomy as well and clear out the sinus at the same time, right? So maybe I should build for the surgical as well. So it's very simple. The prongs go on, secure them to the face, turn on your machine, set a timer. You do have to time things in medicine. You know, I time my rapid sequences, you know, or whatever. I think we lose time. Perception, you know, good data out there that we do lose time when things start going wrong in particular. So I set a timer. I wait a minimum 5 minutes, okay? By the time you, so what I normally do is I do before I even put the drip on. So before the drip goes in, up with your nasal oxygen. By the time the drip is in and everyone's got everything organised, 5 minutes of oxygenation on, you probably get another 3 or 4 minutes by the time you come around to giving the patient the anaesthesia. Give them the Tiva, off they go to sleep. Surgeon moves in straight away. Tells me whether the conditions are appropriate or not. Now we use LTA as well, laryngotracheal anaesthesia. We spray the cords and stuff, so that does help. And surgeon tells me whether they need muscle relaxation or not. They either do or they don't. They continue with their Tiva. Surgeon does their job in 8, 10, 15 minutes. I'm ready watching. You know, you can't go and have a cup of coffee. You can't go on your phone. Which is great for trainees. It takes them off their phones. I don't know if you have that, but we have a terrible problem with the smartphone system in theatre now. We're debating about whether you ban it or not. So. And then the surgery proceeds, and you have everything ready, and you just have to be able to communicate well with your surgeon and say, you know what, I'm going to step in, or ask them, is there any point where I won't be able to step in later? And if they say there is a point, then you can, okay, we're going to intubate earlier. Sure. All right. So you do have to have good communication, and you've got to be on the ball. But it's actually a relatively simple setup. It's just a matter of practicing it, and I suppose eventually we'll get the nurses to do it as well. But it's relatively new, so I'm still myself.
I mean, in our practice in Burton, by the time you cannulate and do the WHO checklist and everything else, it's a good 15 minutes, not just 10 minutes.
Well, that's even,
you know.
it seems to be even better. You know, you're just the longest. You know, it's wasted time. I always feel that we're wasting time in theatre when we could be giving free oxygen to the patient. And when the patient comes in, once you've done the checklist, give them the oxygen. You know, I just tell them it's free and you might as well enjoy it. You know, they charge for it in Brown Thomas and Cork for oxygen bars, so. You know, just...
okay.
All right.
Thank you very much.
Hi.
Not about kids.
No, I just want to know, are you using an anaesthetic room or are you just doing the whole thing in theatre?
Yeah, so our hospital never had any anaesthetic rooms until we built on a new 3 orthopaedic suite, and then they put anaesthetic rooms in. Look, there's a mixed feeling about anaesthetic rooms. They're a big UK thing, to be honest. You know, the idea of a protected room and the surgeon can stay out of it, and that's very lovely and all that. Most of actually hate them. Like, I prefer just get into theatre, get it all set up. So if you're going, you can't do an anaesthetic room because you can't do the surgery there. You're going to waste time. You're going to have to disconnect. You have to move them all in. So I couldn't advise that at all. I'm not sure how you would actually do that. So you're in theatre, you're set up, and you're ready to go. And once the patient goes off to sleep, the surgeon steps in and starts their procedure.
Thanks.
Okay, any more? All done?
Great, thank you.
All right, thank you.